Good afternoon, everyone. It's a pleasure to invite all of you on the behalf of Department of Medical Oncology. I'm Dr. Samir Rastogi. I'm additional professor in medical oncology and look after rare tumors like sarcoma and melanoma. This case exemplifies the journey of a person with sarcoma over 5 to 6 years. And this is such an exciting journey because this is one of our first few patients in which we started immunotherapy. So without much delay, I invite Dr. Rishabh, who is my colleague and senior resident in Department of Medical Oncology, to start the case. Thank you.
Thank you, sir. So, on behalf of Department of Medical Oncology, I will be presenting the case regarding the CCR regarding the hope and solace immunotherapy can offer to some sarcoma patients battling this condition. So, we had a 64-year-old lady who presented with right thigh mass in 2017. She was diagnosed as undifferentiated pleomorphic sarcoma, and she came. A surgery was done. She came with lung metastasis in 2018, and first-line doxorubicin plus olaratumab was given in AIIMS Delhi, on which she progressed. So response evaluation was done after 4 cycles of doxorubicin and olaratumab, which shows progressive disease, as can be seen in this PET scan showing lung metastasis. Subsequently, a second-line gemcitabine docetaxel was given, but in it also the patient progressed, as can be seen in the comparison between PET-CT and CT scan done in January 2019 and May 2019 respectively. So we had a patient who was PS2 and having breathlessness and had progressed on prior 2 lines. The options included either assigning the patient to best supportive care or using a cytotoxic at dacarbazine having low response rates of 5% or giving an anti-angiogenic TKI pazopanib having modest response rates of 6%. Or could we think of something else? So as we were pushed against the wall to think about better options for the patient, we started looking deep into it and started by doing a histopathology review, which would be discussed by Dr. Sunil from Department of Pathology.
So we received specimen from a right thigh mass. So the tumor was the pattern of the tumor was like it was in vague fascicular pattern, and the tumor cells were pleomorphic. You can see there is spindle and epithelioid morphology, and the nucleus shows a lot of pleomorphism. These are hyperchromatic, and some of the tumor cells shows eosinophilic cytoplasm. So on IHC, the S100 and Desmin showed a focal immunopositivity in the tumor cells, which you can appreciate here and here. While CD34, SMA, CD68, and CK, all these were negative in the tumor cells. So our possibility was undifferentiated pleomorphic sarcoma, though malignant return tumor was also kept as a possibility in this case.
Subsequently, we did a PD-L1 testing for this patient, which showed a tumor cell score of 25% and was a positive report, as can be seen. NGS was also done to look for any targetable mutations for this patient, and we found out a PD-L1 TPS of 95% for this patient. And TPS is a marker for how well an immunotherapy could work in the patient. So we had a metastatic sarcoma patient with breathlessness and cough and having a poor performance status. The monotherapy options we had were either pazopanib, which was an FDA-approved agent with low response rates of 6%, or we could look towards pembrolizumab, an immune checkpoint inhibitor, which was recently tried in SARC-028 trial, but the patient number was low, being only 10 patients, and out of which 4 had responded. But the data was still preliminary. We discussed this, the risk and benefit of immunotherapy and the combination therapy with the patient and the relatives, and hence a combination therapy due to modest response rates of monotherapies and a need for rapid response was selected. Hence, the patient was started on pazopanib 800 mg daily along with anti-PD-L1 antibody, pembrolizumab, 200 mg every 3 weeks. This was the PET response evaluation done in our department and would be discussed by Dr. Yami from Immunotherapy.
Good afternoon, everyone. These are the serial CT and CT images axial and coronal section. The January 2019 scan showed ADG lesion in the left lung upper lung, followed by CT scan after chemotherapy done in May 2019, which showed increase in the size of the lesion, suggestive of disease progression. After which patient was started for pembrolizumab and a PET-CT done in December 2019 showed resolution of the metabolic activity in the left lung upper lobe lesion as compared to the January 2019 scan and in terms of decrease in the lesion area. The follow-up scan done after 9 months of treatment shows further reduction in the size of the left lung upper lobe lesion with no metabolic activity, suggestive of stability.
So our patient had a very good response as complete metabolic response after 9 months of mesothelioma and pembrolizumab, which takes us to the question: what is the role of immunotherapy in sarcoma these days? This was addressed by SARC 028 trial, which was a multi-center, 2-cohort single-arm open-label phase 2 trial addressing pembrolizumab in advanced soft tissue sarcoma and bone sarcomas. The soft tissue sarcomas had a subgroup undifferentiated polypleomorphic sarcoma, having 10 patients, of which 4 had responded. As can be seen in this waterfall plot, the change in target lesion size was maximum for UPS patients, which can be seen in the far right, having the most tumor responses. Subsequently, an extended cohort was done for UPS patients, including 30 more patients, and 9 out of 40 patients had response rate, with a response rate of 23%. And subsequently, tumor PDL expression in responders was done, which was 75% in UPS. So in the first half of the story, the patient responded very well to the therapy, but the story is not yet ended, and the second half is full of twists and turns, which will be told by Dr. Chitraksh.
A very good afternoon, everyone. So thank you, Dr. Rishabh, for taking us through the journey of the patient and how we emerged victorious in controlling her disease initially. So the story doesn't end here. The patient received 22 cycles of pembrolizumab till September 2020. She tolerated it very well, with the only reactions being mild infusion reactions and hypothyroidism, which were managed with antihistaminics and supplementation of Veltrox. After 22 cycles, however, in October 2020, she presented to us with complaints of sudden onset shortness of breath, dry cough which was worsening and not responding to antitussives, and desaturation with a room air saturation of 88%. At this time, she was hospitalized and she also required oxygen supplementation via face mask at 8 liters per minute. Naturally, the first thought that came to our mind was, what if the disease has progressed? So we asked the patient to get a PET scan done, and PET scan had shown that the disease was in complete metabolic response still. So to see what was the cause of this shortness of breath and oxygen requirement, we also made the patient undergo an HRCT chest. So as we can see in this HRCT chest sections, we can see there are diffuse GGOs and upper lobe predominant honeycombing and subpleural fibrosis in some GGOs in the lower lobes as well. So these were diffusely scattered subpleural and peribronchial patchy consolidations. And in the PET film adjacent to it, we can see that these were only mildly FPGA-vid and there was no definite nodule which was disease-related. So since COVID was very rampant at that time, we made all possible efforts to rule out COVID. RT-PCR, CBNAT and rapid antigen tests all were sent and they were all negative. Other differentials like infectious viral diseases or atypical bacterial infections were also ruled out. So finally, based on the classical CT appearance and a history of pembrolizumab administration, she was diagnosed as immune checkpoint inhibitor-related ILD. As can be seen in the table on the right side, it was a grade 3 disease since it involved all lung lobes. It had more than 50% of the parenchymal involvement, required hospitalization and oxygen inhalation. So the treatment of grade 3 ILD requires immediate cessation of the immune checkpoint inhibitor, early starting of IV steroids as was started for our patient. Since she did not respond within the next 48 hours, we also added a second immunosuppression, which was the MMF. She had gradual improvement in her oxygen requirement. She became off oxygen in the next 4 weeks, and we gradually tapered steroids and MMF over 6 months. So the patient was continued on single agent pazopanib as we were worried about re-challenge of pembro. After a 10-month PFS and ICI-free interval, she again had progression in the form of new onset lung nodules. So we naturally were again at crossroads of what we should do next. We already have seen that responses with cytotoxics and targeted therapy like pazopanib are less than 10%. And we had also seen that the patient was not tolerating cytotoxic chemotherapy very well. We had seen that the patient had a beautiful response to previous pembrolizumab administration, so we definitely wanted to re-challenge it. However, based on previous data, the recurrence rates of immune pneumonitis are to the tune of 30 to 40% in patients who have developed a prior grade 3 or grade 4 pneumonitis. So we decided that we would re-challenge pembrolizumab because there were no other options. However, in order to reduce the risk of this recurrence, we wanted to re-challenge it in combination with the second immunosuppressant, which is supposed to be one of the strategies which has been tried in a few case series and case reports in these patients. So the evidence till now for concurrent immunosuppression comes from this largest review, which includes the largest study of vedolizumab, which included 14 patients, and other trials, other case reports, which included tocilizumab, benralizumab, and rituximab. And they had seen that with concurrent selective immunosuppression, we can re-challenge immune checkpoint inhibitors safely and get the same response. So this is what we did. We started the patient on concurrent pembro with tocilizumab. So we also were confused between which of these immunosuppressants to start. So we chose the anti-IL-6 blockade, which has a triple benefit. First thing, if we block IL-6 and PD-1 and PD-L1 axis simultaneously, we also get a synergistic anti-tumor effect. Secondly, IL-6 is responsible for differentiation of CD4 cells into pro-inflammatory CD17 cells, which are implicated in IRAs. And a lack of IL-6 in the tumor microenvironment augments the Th1 immunity, and it would increase the efficacy of our immune checkpoint inhibitors by enhancing this immune system. So after re-challenge of pembro and toci, we can see that the patient had complete resolution of these leg lesions in the response assessment scan. And since we were also worried that the patient might have an ILD recurrence, we can see the pre-treatment scan where the patient had developed immune pneumonitis, had florid changes. These had almost reduced by more than 80%, and the patient's lungs were looking much better. So the patient received immune checkpoint inhibitors between July 21 to August 2022. However, the patient's family and the patient wanted a little break from intravenous therapy. Since we already know that immunotherapy has durable responses if the patient responds to it, after mutual decision making, we decided to stop pembro and tocilizumab for the patient in August of 2022. She had a very good treatment-free interval of 2 years, after which on a response evaluation scan, she presented to us again with distant recurrence in the form of lung nodules. So we were again doubtful about what to start, but since we had seen excellent responses with pembro and toci and no IRA again, we restarted the patient on pembro and tocilizumab, and in just 4 cycles, the patient again went into CMR. She is currently doing very well, and as we can see in the scan, this is the pre-treatment scan where she had pleural-based nodule and these lung nodules, which have completely disappeared in the post-pembro and toci scan with just 4 cycles. She continues to do well. She's still receiving pembro and toci, and she's tolerating it very well with no adverse events at present. So the point of this discussion, or why we wanted to present this case in front of this audience, was to bring forward that immunotherapy is also a big thing in sarcomas now. We all know that patients with stage 4 and stage 3 soft tissue sarcomas do very poorly with a median PFS of 4 to 5 months with various cytotoxic drugs or targeted agents, and a median OS of less than 2 years. ICIs have been used in other tumor types like renal cell carcinoma, lung cancer, and it has revolutionized the treatment landscape for these diseases. Additionally, for sarcoma as well, patients with ASPS or patients with angiosarcoma respond beautifully to immune checkpoint inhibitors. However, for other histologies like UPS, we did not have much data before the SARC-028 trial came. So traditionally, sarcomas were considered immune quiescent with a low tumor mutation burden. However, with the SARC-028 trial, we saw that immunotherapy might also work in UPS. Sarcomas as a group are a very heterogeneous group of tumors with more than 70 subtypes and a different tumor microenvironment altogether in all these subtypes. So the patients in this SARC-CoV-2 trial had a highly variable histology-dependent response with only the UPS cohort which responded so well with response rates to the tune of 25%. In a correlative analysis done later, we also found in the SARC-CoV-2 tumor tissue analysis that PD-L1 positivity, a baseline density of tumor-associated macrophages in the tumor microenvironment, the number of cytotoxic T cells and the number of T regulatory cells are all significantly associated with better responses. So if we carefully select tumor microenvironment-based histology in these patients with someone who has a high complex genetic mutation number, which provides higher neoantigen targets for T cells, higher tumor infiltrating lymphocytes as seen in histologies like undifferentiated pleomorphic sarcoma, leiomyosarcoma, and dedifferentiated liposarcoma, we might actually use ICIs to revolutionize the treatment in patients with soft tissue sarcoma as well. So there are a few trials or retrospective analysis that are done, which include immunotherapy use in UPS. The SARC-CoV-2 trial was discussed with Dr. Rishabh, where we found 23% response rate. Another trial of AIIMS A091401, which compared nivolumab with nivolumab plus ipilimumab. An overall response rate of 12.5% was seen, and a clinical benefit rate of around 60% was seen with immunotherapy in multiple histologies, but in the UPS cohort, we had a response rate of 12.5%. Another retrospective analysis revealed response rates as high as 32%, which are much higher than what we got with cytotoxic chemo and targeted injections. So this showed that immunotherapy might be a viable option in undifferentiated pleomorphic sarcoma. To conclude the talk, what we need to remember that sarcoma is an extremely rare and heterogeneous group of tumors, traditionally having very poor outcomes in advanced stages. The main hurdle that we had in the use of immunotherapy in sarcomas was to identify the right subtype or to identify the right biomarker which could predict response. So with the recent trials that I've discussed, we found that undifferentiated pleomorphic sarcoma is one of the subtypes that might respond to immune checkpoint inhibitors. And PD-1 and PD-L1, tumor-associated macrophages, and the number of T cells in the tumor microenvironment are predictive of response. Once we are able to select the right patient with the right histology, ICIs can show an excellent response with very manageable side effects. Even if they develop grade 3 side effects, we have newer strategies to tackle them, and they might add years of life for our patients. Thank you very much. I would like to invite Dr. Sameera Suri, sir, to conclude the talk.
Thank you, Dr. Chitrakshi and Dr. Rishabh, for amazing talk. So, what are we talking about? We are talking about a 64-year-old lady who presented to us in May 2019 with extensive pulmonary metastasis. She had performance status 2 and she was breathless. We were so pushed to the wall and so desperate. We didn't have anything to offer at that time, which was FDA approved and has response rate of more than 10%. So this was the time when we had a case series of 10 patients with 40% response rate in UPS. We bit the bullet, and as you can see, we started on pembrolizumab and pesopenib based upon biomarker PD-L1 and histology undifferentiated pleomorphic sarcoma. And what do we have here? We have so far in last 5 years, patient is still having complete metabolic response, which is unimaginable in era of no immunotherapy. This case was complicated by immune pneumonitis, and of course, our decision was again based upon case reports where IL-6 inhibitor could change the course of immune pneumonitis. So, I mean, we tried best for the patient and we stood by the dictum, do as much as possible for the patient and do as little as possible to the patient. However, there were few toxicities. So, on the other hand, on a more emotional note, this lady was 64 years at this time and now she's 70 years. She has witnessed marriage of her son and she has a granddaughter which is 4 years now. So this is so uplifting to see these families having meaningful life and a good quality of life with the advent of immunotherapy. Of course, it's not for all the patients. It's a very subset, carefully selected, appropriate biomarkers and toxicities well managed. So I'll conclude my discussion with this, and I'm really thankful to everyone, to Dr. Yamini, Dr. Sunil, Dr. Chitrashi, Dr. Rishabh, and all the department who have helped us, including Dr. Shamim and Dr. Adarsh, and the whole IICS Department of Medical Oncology. And this house is open for questions. Valid questions. So yeah, I expected this question because you were there. I mean, absolutely, because she has two sons. So it is a younger son. And, I mean, but she had married. I don't know.
One life in the sun because he has married so late. He should have married before. And I immediately developed excellent. I have very this case. So after you put in this case, then you put a key effort for any case. You are way of taking the patients and extremely enthusiastic and all.
Thank you for the kind words. Thank you.
Never Dr. Sumit as a comment is definitely. But how do you decide how long do you continue? Is it started remember and proceed? How long do you continue?
As you can see, for 2 years we stopped immunotherapy, but she was in complete remission. So again, once she's tired. People are tired of coming to clinic every 3 weekly. So once she says that she wants a drug holiday, then we can again stop this. Again, we can wait for recurrence to happen. And see, this is one-off case. This is undifferentiated tumor sarcoma, rarest of rare cases. So and the literature is as clueless as we are. So we don't know. There is no upper limit to it. In the trial, which had 40 patients, across the world, so many trials, 40 patients so far the maximum data. They gave immunotherapy for almost 1 year. So we don't know, but she is responding, so we'll keep on giving that.
And what is the cost?
For per cycle or for the whatever cost it has entailed, the cost has been huge. So again, things are tailored. It's a mutual decision making. We don't force immunotherapies because they wanted immunotherapy. Yeah, Indian scenario I get it, but from scientific perspective, and they could afford a thing, and they wanted to have this treatment. So scientifically, logically, after mutual decision making, we agreed on this. For them, it's not a concern. But yeah, for general patients with UPS, there are patients with PDL1, and we have not been able to use immunotherapy, which could help prolong this. And it's not covered in AIIMS, so that's unfortunate.
So, which is hypersensitive pneumonitis, I think.
So most common is organizing pneumonia. Second is NSIP. Then there are multiple other. Yes.
It's long-term effect. It's
Yes. I thought it was autoimmune. This, yes.
Yes.
Oh, see, you didn't get the point. The point was we treated with steroids, but we were weak after some time she recurred, and we again wanted to start with immunotherapy. Now we were scared because if you re-challenge only immunotherapy and pneumonitis has happened in the past, then probably we will anticipate pneumonitis again. So with IL-6, there are reports there are very low chances of immune pneumonitis. IL-6 conducts three things. It is immune pneumonitis, immune nephritis, immune hepatitis, and fourth is immune arthritis. So that's why we gave, because we didn't want this toxicity to recur. And as you can see, the toxicity actually diminished.
We are also using IL-6 for the CDD. I thought that it is kind of hypersensitive pneumonitis. It should respond to steroid.
No, it responded to steroids. We are re-challenging here. So if immunotherapy has caused it, so this was re-challenge that made us. We gave steroids first only. Yeah, so this whole thing is about re-challenge, because there are very few reports with re-challenge. Now there is no other option. You want to re-challenge. So we took the risk and we started it. Yes. Yes. No, higher tumor mutation burden is not there. That's what Dr. Chatrakshi presented. They dissected this SARC-028 cohort, and what did they find? They found that these people. This is the okay. I don't find the slide. I'll tell you. So this is the SARC. This is the SARC-028 cohort dissection. What they found that they have extensive immune infiltration. Now, immune infiltration can be B cells or T cells. If it is B cells, it's called tertiary lymphoid structure. If it's T cell, it could be T cell cytotoxic, T cells regularly. They found almost all kinds of infiltrates were very high in undifferentiated pleomorphic sarcoma. This tumor is complex in genetics. It doesn't have high TMB usually. So there are immune cells, there were high T cells, there were tertiary lymphoid structure, and PDL1. Though in various series it was variable. In some series, PDL1 has failed as biomarker, but in this one, almost 8 patients who responded, 6 had PDL1 positive. So yeah, but similar series have failed to show any biomarker. Look, this is the PDL1. So perhaps it is PDL1, it is tertiary lymphoid structure, and it is T cell immune infiltrate. Cardiovascular, sir. I think we haven't seen it. So we haven't seen it. We had few trials of melanoma. We have even sarcoma published quite often. But cardiovascular, either we are missing it, they might be certain because many of them fail, and the disease is the limiting factor. We are not able to perhaps see the long-term thing. Otherwise, hardly.
It is known, but it is less than a percent. It is known.
Myocarditis, which is ICI related, is you cannot re-challenge. This is the absolute contraindication. Fortunately, we haven't seen this is the myocarditis. And if myocarditis happen, you can never re-challenge. So we haven't seen that, fortunately. Sorry. Site doesn't tell a thing. If it is again UPS. And Dr. Adarsh, my pathologist, is saying that it is UPS, PDL1, they often do PDL1. In fact, they have projects running and it is metastatic. Then you should do it. But recently, this ESCO, in June 24, there is an abstract which was presented, SU2C, which had immunotherapy in neoadjuvant and adjuvant setting. And miraculously, that had 20% increase in disease-free progression, disease-free survival. So, neoadjuvant immunotherapy, UPS, majority of patients were UPS and 15% were dedifferential liposarcoma. In neoadjuvant setting and adjuvant setting, it showed 20% increase in disease-free survival. I'm really sorry for that. We'll be mindful for next time. We'll make sure next time it doesn't happen. In 9 years, I got single chance to be here. So probably next 9 years, I don't know. So
That it goes to Dr. Sunil.
So, thank you very much. Thank you very much.